Thank you, Wendy. And now we'll hear from Christie Befort, who will talk about addressing the needs of the rural population.
Thank you. I'm excited to be here to add to this discussion of focus on some of the unmet needs among rural cancer survivors. And I just wanted to comment that I really appreciate the Planning Committee's decision to start this day off by hearing from the voices of a couple patient survivors. And I really wish I had one of our rural cancer survivors here with me today to help really provide some of the context of what it's like to deliver care in this setting. We have very limited literature in this area, and hearing patient voices a lot of times goes a lot further than some of the data that we can provide. But I want to thank Robert for his comments, and just comment that I think we could include patient voices in the context of addressing disparities as well. So I wanted to spend just a minute talking about how we define rurality and who it is that we're looking at when we talk about rural cancer survivors. So about 20% of our country lives in a rural location. 21% of cancer survivors are an estimated 2.8 million individuals. There are numerous definitions of rurality. I particularly like the RUCA code definition, rural urban area commuting areas, which is based on both population density as well as commuting patterns and is at a much finer gradient than our county level based definition, so it's based at the zip code level. This is showing the breakdown of rural cancer survivors using the RUCA code. So about half of rural cancer survivors that are considered rural live in large towns, up to 50,000 individuals, while the other half live in small towns or more isolated areas, with 2% of our country living on farms. There's a wide variation in the proportion of rural residents across states. So, as little as 5% in California and New Jersey, and as high as over 60% in Maine and Vermont. And there's also a wide variation in geographic spread. So in places like the Dakotas, Wyoming, Montana, where 35 to 45% of residents are rural, they live over 99.9% of the land area, so very spread out. In comparison, in the South, also very high proportion rural, but in a smaller land area. Rural residents are more likely to be, do I go back? This one? Oops, I'm going the wrong way. More likely to be white, non-Hispanic, but there are regions in the country and pockets where we have a very high proportion of rural ethnic minorities, many rural Hispanics in the Southwest, a lot of rural African Americans in the South. Hispanic rural Americans are the largest growing racial ethnic group among rural residents, and increasingly moving up into the Midwest, many more recent immigrants working in the meatpacking industry in the rural Midwest. Rural health disparities have been persistent, attributed to multiple factors. This is recent data coming out from the CDC National Vital Statistics showing the disparity in cancer mortality, and the declining rate in cancer mortality is slower in non-metropolitan counties compared to metropolitan counties. And we see this across every single region in the country. Within every racial ethnic group, rurality is considered an additional disparity. So within African Americans, rural African Americans have higher obesity prevalence, lower physical activity, higher mortality, and so on. So these causes are both individual level and super individual, some of them due to socio-demographic differences, but some due to place of residence alone. So access challenges in cancer care in rural America really extend across the cancer continuum, including survivorship care, and certainly have an impact, and we start thinking about how we would disseminate lifestyle interventions to this population. So just to highlight a few of the issues. The first is service supply. It's hard to get specialists to practice in smaller communities. So only 3% of medical oncologists practice in rural areas, 16% of radiation oncologists, and only 2% of social workers. So there's a huge gap in mental health care in rural communities. In terms of financial access, Rural residents within every racial ethnic group are lower income. These communities are increasingly relying on self-employment, which bears out when you start talking about needing to take time off work. It can be harder when you're self-employed. And they have higher rates of uninsured. Of course, rural residents travel farther to receive specialty care, but they also travel longer. So it's the miles and the time that they're spending to receive care. And these maps just show the distance traveled to NCI designated cancer centers at the top, academic-based care, and then any specialty care. And you can see that spread in the Midwest and the Upper West regions to, that time to get to an academic medical center, traveling on average an hour and 40 minutes to receive that care, and in many cases much longer than that. So obviously we need to be thinking about distance-based types interventions in this setting. There's very little national data looking at the health status of rural cancer survivors. It's very limited. Catherine Weaver has begun to try to fill this gap by looking at national health interview survey data. And she found that comparing rural and urban cancer survivors, that the rural survivors were more likely to report poor or fair self-reported health. They were more likely to have 2 or more non-cancer comorbidities, and they were more likely to report the presence of psychological distress. And these differences persisted after controlling for differences in sociodemographics as well as time since cancer diagnosis. Looking at more local data sources and state-level data sources, we see that rural cancer survivors appear to have less knowledge about cancer in general, their own cancer diagnosis, what type of treatment they received. Missouri BRFIS data has shown that rural cancer survivors are less likely to receive a survivorship care plan, so some real gaps in knowledge. Kentucky SEER data has shown that rural cancer survivors have poor mental health functioning, and I've already talked about the gaps in mental health care services available in many of these communities, with higher rates of anxiety, depression, and psychological distress. And a lot of qualitative work has been done, specifically in rural breast cancer survivors, pointing to high levels of unmet support needs. Many women saying they've never talked to another woman with breast cancer. They're really wanting more of that social support component. Lifestyle behaviors, also differences in lifestyle behaviors between rural and urban residents exist as in other diverse groups. 4 out of 10 Americans living in rural communities have a BMI over 30, significantly higher than urban settings. This is where I really wish I had a patient voice to talk about some of the drivers of this difference in obesity prevalence. But certainly cultural eating patterns, NHANES data supports that rural Americans eat a higher fat diet. And if any of you are from a small town and you're used to having dinner for lunch or supper for dinner, it is in many places still very much meat and potatoes. Also, potluck meals are very, very common where every family brings a dish to serve 20 people. And so there's an overabundance of food. It tends to be prepared with lots of added fats. Wendy has looked at baseline data in her RENEW trial comparing across rural and urban older survivors in that study and showed some very distinct patterns of diet between the rural and urban survivors there, with the predominant pattern for the rural survivors in that older sample being heavy on sweets, including sugar-sweetened beverages, as well as sweet cakes and starchy vegetables and potatoes, whereas the urban survivors had a broader range of nuts, grains, and vegetables. There's also differences in social norms around physical activity. So leisure time, physical activity, we heard some comments about this in the African American community, but also in the rural community, that there's not a social norm for that. So this picture here is a small town where my family is from. 200 people live in this town. You can walk anywhere in 5 minutes, and everybody drives to town. I've been trying to get my mom to walk to the grocery store for years. It's a 7-minute walk, and she will not do it. She is afraid people will think her car is broken down. So there's just not the same cultural norms for leisure time physical activity, walking for exercise, or walking for transportation. So very limited literature. I want to highlight a couple statewide surveys that have been done and then talk about some potential delivery mechanism implementation models in this setting. Laura Rogers conducted a statewide survey in Illinois looking at breast cancer survivors, exercise patterns, and preferences. She found, I would like to highlight, 30% reported unknown cancer stage, going back to some of those knowledge gaps. 54% reported no leisure time physical activity, and only 19% reported meeting physical activity guidelines. And she asked several questions in this survey in preparation for thinking about how to implement and deliver interventions. And found similar responses to other surveys that have been done where the strongest preference for location was at home or outdoors. Only 1 out of 5 really wanting to go to an exercise facility to try to exercise. I will say that YMCAs are not widely accessible in the communities that we work in. Great distance that people would have to travel to reach some of these facilities. In terms of preferences for counseling delivery, the most common preference was face-to-face, and this presents some challenges, and I want to come back to this with some of the things that we found. 30% really had no preference, so they're not, not really sure exactly what would work for them. We conducted a survey throughout the state of Kansas, working directly with some of our local community cancer centers, also in breast cancer survivors, and we found, did I go back? We found 40% reported unknown cancer stage. This was the most shocking thing to me, actually, and we didn't give them a complicated definition. We asked, is your cancer metastatic or non-metastatic, or do you not know? And 40% said they did not know. So quite surprising. We asked them what their support needs were. Top rated thing that they wanted was a diet and exercise program, personal training, and support groups. Those that were overweight or obese, this is based on self-report, 68%, 47% of them said, I am trying to lose weight. That could just mean they have a desire, but they framed it as I'm currently attempting. But the vast majority of them were simply doing that on their own without assistance. We, at this point, kind of set out to try to develop something that we could reach this population in our state and our region. And I just wanted to highlight the importance of thinking about an implementation model when you set out to intervene, particularly in populations that have health disparities and that are spread out. So a couple questions in my mind that we have to think about from the beginning as we think about where would we implement this and how would we disseminate it is what's going to be the primary referral source? Who's going to refer patients to the program? How will you recruit them in sufficient numbers? And the second question is, what's the optimal level of clinical integration? Particularly when we're talking about populations, older populations, rural Americans are on average 4 years older than urban Americans who have higher levels of comorbidity, more unmet mental health needs and social support needs. What is the optimal level of clinical integration? Can we deliver direct-to-consumer type programs, or do we really need to be integrated into a healthcare system? Melinda had a slide of several studies that have been done in minorities. I do not have such a slide to show for trials that have been done in rural cancer survivors. So I'm going to share with you a study that we have done and another one that we're doing currently in primary care focused on primary prevention. So we worked with local community cancer centers through our outreach division of KU Cancer Center called the Midwest Cancer Alliance, as well as what was then the NCI Community Cancer Centers program to enroll in a distance-based intervention. So it was entirely remote, except the women did have to travel in 5 times over the course of the study for data collection visits. And their average distance traveled was 60 miles, although went up to over 200 miles for some of them. And we decided to deliver the intervention entirely remote using group conference calls. And we based this decision on 3 things. One, we had some preliminary data to suggest that group conference calls can be more effective in producing weight loss than individual calls. We wanted to address some of those unmet support needs that we had seen in the literature and that we had heard about in some of our preliminary work by getting the women together to talk in real time. And third, we wanted to use a very simple technology that is universally accessible. We didn't want to have any barriers for access based on technology. So we went with this approach. And we enrolled 210 women in this study, and it was a maintenance trial. So for the first 6 months, everybody got the same intervention, weekly group conference calls focused on dietary and physical activity guidelines for weight loss. And then we revealed randomization at 6 months, and the groups were either randomized to continue to receive group conference calls every other week or to receive newsletters in the mail. So two very easily disseminatable approaches. 85% of them lost at least 5% in the first 6 months. And we had some positive findings in terms of the primary outcomes for this study. So we had slower weight regain in the arm that continued to receive the group conference calls, although modestly different in effect size. A high percentage, though, at 18 months hit that 5% clinically meaningful cut point. 75% were below 5% at 18 months. The differential cost between these two approaches was $192 between the continued group conference call versus the mailed newsletters. I wanted to talk, though, a little bit about our recruitment. So our recruitment for the trial we considered a success. We met our milestones on time. Our response rate was similar to the energy trial and other trials that have been done. And the primary method was mailing out invitations with a provider cover letter from the local cancer center registries. And we had a 14% response rate, 9% proceeded on to screening. And this mailing was not targeted based on BMI. So many women would have gotten the invitation who were not overweight or obese. Even though we were recruited successfully for the trial, it presented some concerns in terms of thinking about eventual dissemination and implementation for us. And one of those concerns, I keep doing that. One of those concerns was we only had 5% physician referral rates. Only 5% of the women who enrolled in our study were actually referred by a physician. So it appeared that the ability to kind of integrate this type of referral into a local small oncology practice may not be ideal. Some of the lessons learned from this study was that the group phone-based intervention seemed to engage them. We had 90% attendance to these calls in the first 6 months, 60% attendance from 6 months to 18 months. So good engagement, but declining over time. And as we've heard from several talks, that long-term adherence is really where we need to be focusing. We did process interviews with these women, and that group support and that group accountability was one of the most important things to them, although I will say the cohesiveness across the different phone groups varied substantially. Some of them functioned really well, everybody spoke and bonded, and other ones, you had 2 or 3 people dominating the conversation and everybody else was kind of annoyed. So there's some, some things that happen here that don't necessarily get written up, some variability. I just also wanted to highlight, though, in these types of remote-based trials, we're bringing people in for data collection visits. And I think when that's the only in-person contact that you have with them, that becomes very important. So what we found happening was many of the groups and the women were planning to get together at their data collection visits. So we traveled to all these locations, so we would bring most of them in on the same day. They would say, hey, let's get together afterwards and have lunch and do this and do that, because they wanted some of that face-to-face contact. And I think that's something that we need to think about in these remote programs. Is there some minimal amount of face-to-face contact that's going to enhance the supportive element of it? Another lesson learned, and I haven't heard much discussion of this today, but I'm curious to have more discussion about this, is that there was a high level of new and worsening medical events that happened for women on this study. So we had a data safety monitoring board. We tracked all these events pretty thoroughly, and we had 145 of the 210 women had at least one new or worsening medical event. Wendy talked a lot about frailty. Many of these events were related to falls and broken bones and injuries. We did observe a lot of frailty. We had 35 lymphedema adverse events, which really led us to feel like and come to the conclusion that some amount of integration into clinical care was really essential as we try to implement these types of interventions to breast cancer survivors who probably carry a higher level of comorbidity. I just wanted to mention a trial that we are doing right now focusing on implementation models of care in primary care in rural settings, where we're comparing implementation locally in the clinics versus remotely using the group conference call method of delivery. We have 36 primary care sites that are implementing this, mostly in Kansas, but also in Wisconsin and Nebraska. And we're in the midst of enrolling right now for this study, but one of the things that we're finding early on is that uptake at the patient level seems to be driven more by clinic variation than by variation in the different intervention delivery modalities. So that's shown here. Range across clinics in the recruitment rates is from 5% to 31%. So huge variation. And I want to put a call out that I think we need to be starting to look at more contextual clinical factors that are going to influence patient uptake. And there's some nice models in the implementation science literature. Consolidated Framework for Implementation Research is one of them, where we can start to put a framework around what are the important setting contexts that are going to influence how many patients actually enroll and actively participate in some of these interventions. So I'd just like to end with a few suggestions for additional research and opportunities. Throughout all of our talks today, I think there's been a comment that we need more research on cancer types other than breast. That is true in the rural setting as well. We tend to have the assumption that when we're delivering interventions to diverse populations that they need to be tailored to that population. I certainly think that's true anecdotally, but that's an empirical question that I think deserves more research attention. And, you know, if we're going to tailor, there's certainly regional variations that need to be addressed and variations that need to be addressed among rural residents that are racial ethnic minorities. And then this question about what is the optimal level of face-to-face contact. I'd like to see more studies answering that empirically. I think have gotten into the mindset of assuming that we need to go remote, but if you talk to patients, a lot of them will tell you they really appreciate some level of face-to-face contact. We need to continually be thinking about capacity in clinical settings and potentially some of the downsides if we start moving more towards direct-to-consumer type remote interventions. I also would like to advocate that rurality be designated as an underrepresented group officially. I think this would help us start to use a common definition across studies so that it makes comparisons makes it easier to compare across studies. I believe this group should be included in our inclusion and enrollment reports and targets and catchment area needs. We need more research across the board, observational studies on determinants of these health behaviors in rural settings. I would love to see some planned rural-urban subgroup analyses in some of the larger studies that are being done, and then program announcements on specifically calling for effectiveness implementation hybrid designs on lifestyle interventions for cancer survivors. And I will end there. Thank you.